someone wanted to ask, will marijuana help? Any studies on it?
Well, as I noted during my presentation, there's no objective evidence that marijuana helps, blepharospasm, but there are many anecdotes that patients tell me that when they smoke marijuana or have edible marijuana, that it relaxes them and it enables them to keep their eyes open. So to my knowledge, there has never been a formal study on marijuana and blepharospasm. The article that I showed reviews all the evidence for and against marijuana in a variety of neurologic movement disorders. It might possibly be useful in patients with tics and Tourette syndrome, in perhaps some cases of patients with Parkinson, but in most cases of movement disorders, there's really no evidence that marijuana helps. It doesn't mean it doesn't help. It's just there's no evidence. The studies have not been done.
You still have the squeezing, but you won't cure us.
Okay, thank you. This is an interesting question, but maybe for Dr. Anderson. Someone asked if we're interested in eye donations for research.
What was this?
Are you interested in eye donations for research?
Unless you have tumors in your eyes, I don't do general ophthalmology. So I occasionally have to take eyes out for tumors and things like that. But an eyeball donation really wouldn't help us with blepharospasm, if that's what you're asking.
Okay. All right, so maybe Dr. Pelak can answer this one. What causes the double vision after Botox injections?
Well, there's a couple of reasons you could have double vision. One is just plain dryness if you have ineffective blink, for instance. And those are relatively easy to figure out. If you close one eye and you still have double vision out of just one eye, it may be due to the dryness. Now, if you close either eye, it doesn't matter which one you close, and the double vision goes away, it's possible that you have some weakness of some of the muscles that help move the eyes and stabilize them and allow them to work together. And so an examination after you experience double vision will be very important to figure out which one of those two things it is, because if you, as you can imagine, if it's dry eye, you'll want to get that treated very quickly. If it's double vision due to muscle weakness, that should go away with time. So if you're used to getting double vision after your injections, it's best to have that evaluated so you know which one of those two conditions it could be.
Okay, good. So maybe this could be for Dr. Jankovic, but others can probably chime in. There's several questions about Botox injections and wondering if it's a hit or miss adventure. And are there any injection sites that might be more effective? Others comment that, does it need to be important about the location? Sounds like they get partial relief, those types of questions.
Well, like in anything, location is very important. And it's not just the location with respect to the technique of botulinum toxin. It's important that the physician really fully examines the patient, is familiar with the condition, with the anatomy, and then treats the condition appropriately. Most of the patients who are referred to us with the problem that they are not responding to botulinum toxin for one reason or another, in almost all of the cases, it's a matter of dosing, injection techniques, and things that can be fairly easily addressed. As I told one of the participants over the break, in thousands and thousands of patients I've seen with blepharospasm, I have never, ever seen a patient who did not respond. Now, I have seen patients that may have not responded as well as he or she and I would like, but all patients do respond to some degree. And if they don't, you adjust the dosage accordingly and adjust the technique. But essentially, all patients should respond unless they have immunoresistance against botulinum toxin, which rarely can occur in military personnel. For example, during the Middle Eastern wars, some of the military personnel was vaccinated against botulinum toxin, and they obviously had what we refer to as primary resistance to botulinum toxin, but is extremely rare.
Interesting. This is for Dr. Hallett. Can specialized eye creams, I guess they might be speaking to the botulinum toxin creams, reduce blinking by the cosmetic function or wrinkle reduction?
Well, actually, it was a question like this that we got, I think, not at one of the meetings, but sent to the main office that got me interested in that particular possibility. So there are some creams that are used for wrinkles at the moment, and the cause of wrinkles is muscle contraction in the skin, and one would think that it might be possible that the muscles in the upper eyelid are relatively superficial and might be something that could be targeted similar to wrinkles. So we have tried some experiments using a particular cream that is on the market for wrinkles called AH8. We had one trial that looked like it might be useful, but then another trial, double-blind, did not find usefulness of it, and so we have stopped those studies. However, there are other companies that are trying to develop creams that where there might be something that could go through the eyelid and be helpful. Whether that will work or not in the long run, it's not clear. Dr. Jankovic mentioned one in his talk. So it is possible that something like that will eventually come around, but we don't have it available right now.
Dr. Anderson, would you do an operation before someone tried or demonstrated a failure to Botox or botulinum toxin?
I have had, I think, in the last, since Botox has been available, 2 patients who just said, I'm not taking that poison, I won't have it in my body. I strongly encourage everybody to try it and try it with me if they've tried it other places and it didn't work before we do that. These 2 gentlemen were not going to have any neurotoxins, so period, and they couldn't keep their eyes open, so I did myectomies on them. But that would be the only ones.
Yeah, thank you. Dr. Pelak, could blank contact lenses help with dry eye?
Blink contact lenses?
I think it says blank. So I guess it means non-prescription.
Potential to help protect the dryness. Yeah. So understanding that blink reflex is probably key, that we know, as I talked about, that any ocular surface disease or eye surface disease is going to cause the plasticity that was talked about with an increased trigeminal reflex. And if that contact lens for you, depending on what type, where it fits, and who fits it, decreases that sensitivity to things like wind, for instance, or dust or particle in the eye, then yes, it's possible that you may have a decreased blink reflex. But just like the marijuana question, we don't have a lot of answers when studies haven't been formally done. So that would be something that certainly could be tried.
Let's see, Dr. Jankovic, I guess, do you think more frequent injections of botulinum toxin can be approved?
Yeah, that's a very important question. I tried to touch on that by showing that one slide of a survey that clearly demonstrated that most patients would prefer having the injections more frequently than every three or 4 months. There used to be a major concern about injecting patients very frequently because studies have shown that when injecting patients more frequently than every 3 months, there is an increased risk for developing resistance due to development of antibodies against botulinum toxin. And in the very, very early days of botulinum toxin injections, there were some investigators who would do what's called booster injections. So if the patient didn't respond to the first injection, they would be invited to come back 2 weeks later and be re-injected. And those were the patients who had a very high risk for developing antibodies. And this is especially relevant to patients with cervical dystonia, with neck dystonia, because they require much higher dosages. Over the years, there has been much improvement in the purity of the toxins, and immunoresistance from botulinum toxin has markedly decreased. Having said that even with these current preparations, there is still a possibility that patient will develop a resistance. The risk is much lower. It's only about 1 to 2% of patients develop resistance, but nevertheless, it's still there, and it's obviously much higher in patients who require higher dosages. So in patients with blepharospasm, where dosages are relatively low compared to patients, let's say, who require injections for cervical dystonia, the risk of immunoresistance is relatively low. So more and more physicians are now using this approach of, a shorter injection interval in order to avoid the wearing off, effect. There are studies currently underway by essentially all the manufacturers of botulinum toxin to address this question, and hopefully within the next year or two, we're going to have more data. So we are again invited to Madrid in January 2017, Toxins 2017, where some of the data will be presented.
Excellent. I'll volunteer to go to Madrid. I'm there. Dr. Hallett, this is a question that comes up quite a bit, is this concept of TMJ and dental implants. Usually it's in cervical dystonia, but I've been asked a couple times now in blepharospasm. Do you see any role?
I think basically the answer is no in my mind. There are a number of people that have cranial dystonia or other types of dystonia in the face, and you'll hear some oral surgeons or dentists claim that this is due to abnormal temporomandibular joint, and they will give some sort of implant in the mouth and claim that people are cured. I must say that I haven't seen that, so I don't think that there's a connection. That would be my own view, although it is somewhat controversial, I know.
There's another side to this question, and that has to do with TMJ, the relationship between cranial dystonia and TMJ, temporal mandibular joint syndrome. So patients with blepharospasm often develop spasm of other muscles, including the jaw muscle, the masseter muscles, and that can cause grinding of the teeth and also increase pressure on the temporal mandibular joint. So there are many, many patients with blepharospasm who develop bruxism, which is grinding of the teeth, and develop a secondary TMJ syndrome, and that can be effectively treated with injection, particularly to the masseter, so occasionally the temporalis muscle. Is a very important point to keep in mind because many patients lose their teeth because of this constant grinding of the teeth, and it can be effectively treated and prevented with botulinum toxin.
Good. All right. So, Dr. Anderson, someone wanted to know if after they've had a surgery, do they still require botulinum toxin injections?
Yeah, the best results are in the people that get the benefits of both. And as I said, unless I absolutely have to, I don't do lower lid myectomies anymore. So the lower lids, the cheek area, the bunny scrunch lines, the nose, we're not cutting those muscles out. And so those areas, usually I tell people they should wait at least 3 months because they need the lower lids to help them close because the upper lids aren't closing well before they consider having shots in those lower lid areas. And if there's other areas where maybe I missed a little piece of muscle like the inside of the brow or whatever, any of these areas can certainly be injected. The central portion of the upper eyelid should never need, well, you can't inject there in the first place, but I would say the doses have been shown to be about a third of what they were before surgery that we're using, and the number of sites are about a third of where they were. And some people go on several years before they go and get shots. I tell them all they should get shots when they need it, but there's a few people that just say, hey, I don't need them anymore.
Good. Well, there are also a couple questions from people, maybe everyone can comment, but wondering if there are any supplements that may be helpful or are they a waste, and some specifics for omega-3, for example, or fish oil, or some other supplements. Any thoughts?
Omega-3 may be useful in dry eye. So if you are somebody that has dry eye, and although it may feel that you have dry eye, it takes an examination really to confirm that. In those instances, omega-3 fatty acids have been shown to be useful, as well as flaxseed oil. And these are things that you can get over the counter that could be useful. And if somebody else wants to speak to any of these dietary supplements that haven't been studied.
Well, perhaps that sort of brings up the topic of coffee, which is a question that I often get asked about. It's very clear about coffee and people coming down with blepharospasm, but people will ask, well, now that I have blepharospasm, should I drink more coffee? Mm-hmm. Will that help? And I don't think there's any evidence for that. So that by the time that you do get blepharospasm, it's too late, as far as we know in that regard.
And I think Joe mentioned zinc. A couple of my ex-fellows came up with that paper, and I'm not certain about it, but I think there is a value to people at least taking zinc and having their zinc levels up if they're using botulinum toxin.
But I don't think that should be used as a supplement. If you really want to try zinc, there's a medication called Zytase, for example, that has zinc in it, and that should be really prescribed by a physician with specific, instructions. But with respect to the supplements, I always tell my patients the people who benefit from dietary supplements the most are the ones who sell them, not the ones who take them.
That's a good introduction to the next question, which would be an extension to alternative therapies such as cranial sacral therapy, biofeedback, meditation, hypnosis. So is there any suggestion that those are helpful in blepharospasm?
So I think it's in a different category than the dietary supplements. Dr. Anderson and I were reminiscing last night about one of our earliest meetings we had. We invited one of my colleagues, Arthur Tarbox, who is a neuropsychologist interested in biofeedback, and he presented some interesting data, which was clearly a scientifically done study that did show that biofeedback, for example, could be beneficial. Mm-hmm. And I mentioned some of the other muscle relaxation techniques. I think they are useful, and they are usually not terribly expensive, and they don't usually have side effects. So I would recommend it as a supplementary treatment.
And I think acupuncture works better if there's Botox.
Good. So there's just a question about gabapentin and Lyrica specifically, whether they can cause blepharospasm, but I guess I would extend it maybe, Dr. Hallett, to do those medicines or other medicines cause blepharospasm?
Not that I'm aware of. Is anyone aware of that?
Well, what about for gabapentin?
They don't
cause blepharospasm, but they sometimes might be helpful particularly if there's associated pain. So I do prescribe those kind of medications if there is a great deal of pain associated, with the blepharospasm.
What about neuroleptics, antipsychotic medications?
Neuroleptics are very, very important to keep in mind. I mentioned it in my presentation. There's a whole class of drugs that are used for a variety of psychiatric disorders that block dopamine receptors, and because of that, they can cause this condition called tardive dyskinesia, tardive dystonia. And many of these new drugs that are referred to as atypical neuroleptics are marketed by the manufacturers as very safe drugs, quote unquote, and they are not. So, for example, Abilify is the number one drug prescribed in the world right now, and it's manufactured by the company as an atypical neuroleptic with very low risk of side effect. Yet I've seen dozens, if not hundreds, of patients with tardive dyskinesia from Abilify. So this is just a word of caution. Just because the manufacturer claims that they are safe, it doesn't mean that's the case.
Yeah, I would agree. Seen the same. Dr. Pelak, are there negative effects to ongoing dry eyes?
Yes, there can be. So one of the areas I touched on is that if the cornea has some erosions on it, that can lead to a worsening chance or a higher risk of developing infection, for instance. And the more erosions you have, the more feedback, the more sensory stimulation you're going to have to that feedback loop that seems to be all important in trying to decrease the number of spasms you're having. So the more dry eye you have, we often say the more dry eye you can get because of that vicious cycle, the possibility of increased infection too. So.
Okay, good. So I have not heard of this medicine, so medication. Has anyone heard of Sefalee? And it says, does FDA approve a product called Sefalee for blepharospasm? Has anyone heard about that medication? Well, they spelled it Cefaly. I'm not sure I know that one. Mm-hmm. There was a couple questions about brain MRIs, and I can just answer that in blepharospasm, you may get a MRI or other imaging of your brain. In general, those scans would be normal. We expect them to be normal in blepharospasm, especially if it's the isolated dystonia type and not one caused by some other condition, some Parkinson's condition, something like that. So some of the abnormalities that I described in my talk are really sort of on a research basis right now. And so they're not, it wouldn't generally be used, you wouldn't be able to glean any information about your case, but you would hope that it was normal. And so that's what I would say about that.
Yeah, well, the reason for doing it is really to make sure that it looks normal. People that have primary blepharospasm, which is most of the people here, MRI should look basically normal. And if your doctor orders it, they want to be sure that you don't have secondary blepharospasm.
Okay. So here's a question about alcohol and blepharospasm. One, does it help or aggravate? And specifically, how about IPAs? No, I'm just kidding. That's my question.
So one condition we have not talked about in the symposium is a condition called essential tremor. We talked about essential blepharospasm, we didn't talk about essential tremor. So essential tremor is probably the most common condition. It can cause tremor in the hands, it can cause tremor in the head, and it's a genetic condition, autosomal dominant. Each offspring has about 50% chance of developing the condition. And that condition exquisitely responds to alcohol. Many patients with blepharospasm or with cranial dystonia and cervical dystonia also have this condition called essential tremor. And there have been many, many papers published on the relationship between essential tremor and dystonia. So patients who have both conditions, they often say that alcohol relaxes them in terms of the tremor. And in some cases, they say that even the blepharospasm gets better with alcohol, but that has not really been fully confirmed. But there's no doubt that alcohol is an effective treatment, not recommended, but is an effective treatment for essential tremor. There are many other medications that are used and are safer for essential tremor than alcohol.
Okay. So maybe we'll do one more question. And maybe this is for Dr. Jankovic as well. On those list of medications that you showed for the potential treatment of blepharospasm, is there anything detrimental to stay on the treatments, such as, for example, clonazepam for a long period of time or Artane?
Right. I'm not a big proponent of any of these medications that I mentioned. I do use them occasionally to sort of get the patient, for example, from one situation to another when they are wearing off from botulinum toxin, and let's say before we can do the next injection, if they wear off very quickly, and I don't want to inject them too soon, then I may use these medications just to tie them over, using clonazepam or Artane or one of these other medications. There's no strong evidence that using these anticholinergic drugs will cause any kind of damage, but they can certainly cause a variety of side effects that I mentioned, and rapid withdrawal from the medications can be very, very serious, including even fatal. And this is especially true for clonazepam. So clonazepam or Klonopin, even though it might be helpful for blepharospasm, should be used for short periods of time. If the patients are on a chronic treatment with clonazepam and the physician decides to withdraw the patient from clonazepam, has to be done very, very carefully, very slowly, in order to prevent withdrawal reactions, including seizures and death. Right. I don't want to end on this. You have to ask one more question that has to end on a positive note.
Indeed. Okay. All right. So we could say, Be a positive question. Well, it says, is marijuana being studied for spasms? And it's a little bit happier of a topic. So we were in Colorado. The Colorado Department of Public Health put out a request for applications for grants for research studying marijuana for various medical conditions. And so we do have a study looking at Parkinson's disease tremor with marijuana. So we don't have spasms, but in a sense, this is looking at tremor. And it's going to be studying it on a very controlled basis with the placebo so that we can really get a sense if it works or not. And so stay tuned for that. And maybe in the future, there'll be a study of it with Blepharospasm specifically. But as Dr. Jankovic reviewed earlier, there's no evidence right now that it helps with Blepharospasm, but it needs to be studied formally. All right, well, thank you.